Morning, everybody. Thanks for coming. I think we'll start. There are a couple of people meant still to come back from their 15 steps challenge, but we've got a lot to get through today, so I want to keep to time. So, first thing we're going to do is get the feedback from 15 steps. For those of you who've not been here before, that's when our execs and non-execs pay an unannounced visit to a ward or a clinical area and have a look to see what they see, talk to some staff, talk to some patients, and come back and tell us the good things and the things that perhaps aren't so good. So I was going to ask Daniel to start, but he's gone on the phone, so I will ask. We can start. Right, Daniel, would you like to start with your visit to Swelliok with Aruna?
Okay, so it's so nice going into Swelliok because everyone is so universally positive, and the patients are so incredibly appreciative of the very attentive care that they have had, and it is spotless. And the highlight for me was going into one of the nurse staff rooms, the ward staff rooms, and seeing the governance board. And on the governance board, they had the "What does good behaviours look like from your voice, your values?" with a complaint where the patient had said, "You didn't treat me properly," and they had gone back to the what good behaviours look like and written up for those members of staff what they needed to do to ensure they provided great training. And then they had a great care rather, and they had another paper on the piece of paper on this governance board, which was what they'd learned from the last incident, with a description of the incident and the learning that they had to take from it. And I've taken some photos, and I think they will find it into my weekly message in January, because it seemed very good. So that was my highlight of it.
Yes, I will add to that. I mean, very, very positive patient feedback. There wasn't anything. I spoke to 3 patients, and I actually asked them categorically, is anything we could do better or different, and they still can't think we could do better or different. We've been so well taken care of and so well treated. The other real positive thing for me was on the nursing front, really, where I was told about a nurse that was given leadership training to lead a department in a different way, which I thought was very, very positive. And the other thing is a different way of plugging our nursing gaps. So theatres, we have a shortage of nurses, and we're actually looking to bring in apprentices and use apprenticeship levy to train up people that aren't registered or nurses that aren't registered to make them registered nurses in a very kind of structured way with the university. So I was very, very reassured. I mean, we all know there is a huge gap and shortage of nurses, and here we are doing, something that is outside the box and creative, and I think that's wonderful. So yeah, no, very, very encouraging, very positive.
Good, thank you. It's always good to start on something positive. Dan, would you like to take it?
I went to Evesham and Casey. So for those of you who are unaware, Evesham is a treatment area, somewhere we use as a paediatric assessment unit, and also a outpatient, a long-term treatment area. It's a well-known brand for paediatric patients. And this summer we underwent a building project to move it up one level, so it's now on the same floor as Casey. So the inpatient ward and the outpatient and treatment area are now adjacent. So I went up to have a nose around the new build area and also to walk around Casey. So I started off in the new Evesham, who were perfectly happy with their staffing levels today. In fact, they'd lent one to paediatric outpatients to support today. They liked their new unit, and they said the patient feedback had been good. Their one concern was about the level of oxygen cylinders we had on the wards. So we put 4 cylinders on the ward with 2 next to the beds, and a patient came in at the beginning of this week and had consumed the one next to the bed and 4 of the spares and had got through a huge amount of oxygen. So there was just a concern about whether they had the right level of stock holdings on the ward, and that's something we'll take away and look at, because we weren't able to pipe the oxygen up there during that phase of the building, and that was the mitigation, and we seem to have got through it at a faster rate than we'd anticipated, so we'll pick that up. I then went on to Casey and chatted to the nurse in charge there, Rachel, and a couple of the other nurses. The ward round was underway. They're quite full of patients at the moment. They were full to capacity at 18. They were down a nurse because one of them had called in sick at 6:30 this morning. So I'd asked in both areas, do you know who to escalate to? And in both areas, they gave me the names of the people they would speak to. And then whilst they couldn't necessarily name above that, they knew who they would call or what number to call and what role they were trying to get in touch with. They thought that the level they had was on the level of being safe, but they were worried that if with the acuity of patients throughout the day, that might require some of the nurse in charge to work within the numbers, and they were escalating that as I was walking around the ward. And their main concern was both about the nurse staffing levels and also the impact of the paediatric bronchi season this year, which has been particularly severe. And that has meant they've sometimes had to escalate to every single space they can use on the ward. And the balance of our paediatric staffing numbers between ED and Casey ward has been quite difficult to manage. And they were reflecting that high level of acuity mapped to the numbers they had available, and that was a concern for them.
So this whole business with paediatric chest issues, is this something that happens every year, and is it worse?
So it normally happens twice a year, once going into winter and again coming out of it. What we have experienced and what public health have warned more widely is that this year the RSV has hit particularly it's the respiratory syncovirus, which normally goes with bronchiolitis. Syncytial. Thank you. I can never remember what the middle word actually stands for. But it has hit harder, earlier, and younger patients than normal, and that's been the impact. So at the beginning of this week and last week, we had significant ED delays because we physically couldn't process the large numbers of patients who were arriving, many of whom needed a bed. So we went out to the London bed service, but we were calling hospitals as far as Portsmouth and Brighton, and there wasn't a bed to be had anywhere down the A3, M25 corridor for a PEDS patient. So it's been a particularly severe season this winter.
Is there any sign of it letting up at all?
Not yet.
Right. Thank you. Well, thanks for letting us know. It's important that we understand this, and certainly from what you said, Public Health England are aware of this and have told everyone. It's just really difficult, isn't it? Because even though you're aware of it, it's very difficult to actually do anything if you haven't got any space or any people. Okay, thank you. Good. Next on my list is Sarah, who is our new Deputy Chief Nurse. Hello, Sarah. Hello.
Everybody, nice to
Hello.
see you.
And I think you're on day 4 or
I'm on
5,
day-
possibly.
Yes, end of my first week, so learning lots.
Where did you go?
We went to the surgical
With-
care unit.
With Pat. Okay.
With Pat, who's got a microphone, so I don't know if
Yeah.
you want to start, and then I'll shift in.
Yes, Sarah and I went to the surgical assessment unit, which is where all patients for planned operations, whether they be day cases or not, wait. It's a unit that was refurbed from doctor's quarters 18 months ago, something like that. It looks very nice and fresh, all the lighting works, it's clean. It's quite crowded. It was apparently quite a normal day. Patients are allowed to have one member of their family, one friend with them, and all the seats were full. They've been there since 7 o'clock. All of those of you who've had operations recently, like I have, will know that it's quite hard if you're not going to be coming on until 11 o'clock and you come in at 7 and you can't eat or drink anything. So those are obvious issues for patients. And I did ask some of the patients whether they knew any idea how long they were likely to wait, and they didn't. And I think we could do more to try and, even if you can't give a time, to indicate how the list is going, just to communicate so that people are aware that the staff are aware you're waiting, because it feels a very long time. So I think that was the main issue for them. For the staff, it is a very crowded environment when everybody's waiting before the list has really got off the ground. The lists, there were 6 this morning, 6 lists. And they only have 3 consulting rooms for the consenting on the day, and they also double up as places for the patients to change when they are called to theatre. So it really is quite a logistic issue for the staff to get that to work smoothly for the patients. Most of the patients this morning hadn't discovered that yet because it was early, but it doesn't sound ideal to me. But I mean, it's a space constraint, and presumably there wasn't anything we could do about that. But it was quite stark from that point of view. Sarah, did you want to add anything?
I would agree with all of those points. I think the very positive thing, the nursing staff, we spoke to Heather particularly, who was his staff nurse, who works with a colleague on the shift. It was nice to see colleagues coming as well from the surgical wards to check they were okay where they work from. They feel very positive about the way they're supported by their managers and the way that they're led. They feel that they can raise concerns very easily. The issues you've highlighted, absolutely they highlighted to us, but equally felt that this is a nice place to work and they enjoyed it. So that was my positive that I took away as well.
It's probably worth adding that the lack of space for pre-theatre is a known issue. And one of the reasons we moved what is Evesham up a floor was to repurpose that space downstairs, and that's going to become the theatre day unit from April onwards. And that will then allow us to do all the consenting downstairs, and the space you visited this morning will then become a holding area, so you move patients up who are ready to go into theatre, but everybody else stays downstairs, and there'll be a lot more space with much better facilities and more room for consulting. So that is in hand at the moment. There's some estates works going on in that space to repurpose it so we can use that.
That's very good news. And I think that will obviously resolve that issue. I do think the issue of communication, I mean, we talk about communication all the time, and I do think we need to see it in an area where, in a sense, people are just waiting, there's not much going on, and for the staff too, it's not apparent that they are interacting with the patients.
I think there's some things we could do quite quickly with the signage, for example, just to make things easier for patients to understand. So Eileen and I'll have a look at that as well.
Lawrence, I wonder if I could just add. On Wednesday, Daniel and myself had the pleasure of being with the anaesthetic department, receiving the AXA accreditation, which is the Anaesthetic Clinical Standards Association. And it's a watermark of good governance and clinical care that the anaesthetic team provide. So we received a sort of embossed certificate, and we were wondering where we should display that, and perhaps that's a good place to display it. We're the 25th hospital in the country to receive this, and in London, in the Thames region, we're alongside Homerton, St George's, Kingston, National Hospital for Neurology, and now on the website, Epsom and St Helier. So hopefully that will give patients a little bit more assurance when they come into that area.
That's very good. Thank you. I'm always in favour of displaying certificates, particularly if they're embossed. So I mean seriously, that is good, and we're with a select group of other hospitals. Good. Let's move on to Croft. That's Thursday. You went to Croft. Thank you.
I did, yes. I went by myself, and I've never done 15 steps before, so you have to caveat some of the things I'm saying in that context. So Croft Community moved to Epsom Health and Care, which is our integration programme, in October of this year. It's a GP-led unit, and it looks after people when they've passed through their acute phase of their illness. They need a longer time to recover and look at what care they require in the community. I suppose the overwhelming impression that I have from going there is a sense of calmness and positivism that I haven't had before, and that was really impressive. The staff were incredibly proud of the work that they were doing, and when you asked them what they were proud of, they gave examples of patients who'd been admitted who were going back to their own home when everyone thought that they wouldn't be able to. So the fact that they deferred to actually talk about patients was very impressive. They've had some minor works done on the ward, and they're very pleased with those, and they're looking forward to the further work that's going to happen. They are very clear about how they would escalate things. They never feel that they are left without support, both from within Epsom St Helier through the nursing structure and through Epsom Health and Care, and that's very good. The thing they are looking forward to most is when the escalation area on Croft is closed, and they can use that as a therapy and a rehabilitation area. And at the moment they are losing therapists who are very excited by the prospect of what Croft can be, who can't actually deliver it at the moment because there is no space to provide that therapy support. The patients were very complimentary of the care that they'd received. They said that it was very good and very kind, and those are very nice things to hear. Asked about the concerns that they had, interestingly, one of their major concerns was around boredom. So actually the activities that are provided are really essential to the staff.
Thank you very much. Anyone, any comments on the community? Thanks very much, Thursday. But I mean, I'm not sure if everyone knows, Thursday is our our newest executive director, who is responsible for that whole side of life, which is essentially going to be new to the trust, of the community work, both for Epsom Health and Care and Sutton Health and Care, and bringing all the people who are coming to join us in the new year, in March, bringing them into the trust and making sure that our service is as integrated and seamless with social care as possible, because clearly that's really important for the journey through the hospital and making sure that we can continue to deliver on the standards. Thank you, Thursa. Next up I have Peter and Richard, I think. Am I right? Right.
So Richard, Debbie and I went to 3 related areas to the emergency department. So we looked at the newly built rapid assessment and treatment area, which was not yet open because they've got some working through the staffing complement necessary to make it open effectively. But you're clear that it's all been kitted out and ready to go, but it's not yet functioning because of staffing issues to resolve. We also went to the clinical decision unit, which is again in a new space, but not a new function and area, and the staff and the patients I spoke to there were kind of, happy with the way they were working. They liked the new environment and understood, and we didn't feel kind of out of touch because they got lots of input from more senior colleagues coming through. We also went to the hub, which is run by the sort of allied to the acute medical unit, and it was being cleaned. There were no patients in there at that moment, but the common theme was that one of the ED nurses had come across to cover because there wasn't a senior sister able to cover the shift. So making sure we've got the right staffing in place is clearly challenging to deliver the service, but it was clearly everyone was pleased with the new physical environment and how they understood their roles in making that work. The other element that we heard from was in the hub was making sure that there is sufficient kind of cover from the AMU with the doctors coming down rapidly to see the patients in an effective time frame. It wasn't something that was sort of they weren't flagging it as I say it didn't happen, but it was something that they clearly were conscious they needed to work at. On the way back, we also came via the urgent treatment centre just to pop in to see all of those related areas to ED rather than the core ED, and that was very calm as well. The receptionist staff had commented that they were feeling a little bit exposed. There's apparently some planned work to put a low perspex screen in rather than having just a low desk, and they said that had been agreed but not yet happened some months ago. So it would be, if someone can have a look at that. So they felt that partly children were fiddling with the wires because it was a low desk, and they also commented about making sure they felt appropriately secure, particularly at night if they don't want to pull the shutters down even if there's someone there, but it's making sure. So I think there needs a bit of a review to make sure we've got the appropriate kind of not barrier, so it's not kind of a physical barrier that people are hiding behind sort of glass necessarily, but an appropriate arrangement for suitable empathetic interactions, but also a degree of safety. But otherwise, those were the kind of the highlights from what we saw. Richard.
Yeah, if I could just add, I mean, I found the whole thing fascinating. So I asked a lot of really dumb questions around patient flow, and it's clear that a lot of work has gone into thinking about patient flow, and we've obviously there's been a lot of investment in the area, and I think it's a huge credit, and quite frankly, I wonder whether in some shape or form we can publicise a little more clearly what has been achieved there. I think maybe for sort of the public briefing at some stage. I mean, it'd be lovely just to have a little diagram almost that illustrates how, whether a patient comes via ambulance, self-present, or a referral from GP, what the different pathways are that that patient might go through. Because, you know, a huge amount of thinking has gone into this, and it makes for a much more efficient patient pathway. And I think it's a huge tribute, and it's a great success story. So I personally would advocate that we maybe share a little bit more of that with our with the public.
So you don't have to advocate very much, because our regulator is lining up for the media to come and do a tour of the two A&Es, because they're really impressed by what we have actually done. Because we know we were given the money not very many months ago to expand both departments, and we spent it well, and they're thinking, and they can actually see the difference in the A&E performance as a result. So they're coming with the press.
I think a neat little schematic would work and treat that. Because it is a little bit complicated as to how patients might move from one area to another depending on what's required.
Could I just add, I'm really glad that you've seen some of the improvements, and one of the things that we've noticed is that the medical community are starting to be attracted. So we've just attracted 2 joint AMU care of the elderly consultants who are coming here specifically because of all the work, innovation going into patient pathways. So it's starting to have a recruitment impact amongst doctors as well, which is really positive.
Good. Thank you. I think this was slightly after that. Was that it? Debbie. Sorry, did you want to... Oh, you're right.
No, I think I'm...
You're okay. All right. Well, thank you very much, everyone. Oh, Elizabeth, sorry, you're missed off my list.
Oh, no.
I know.
How could James and I have been missed?
I know, this is dreadful. Right.
Do you want to know where we went?
I do.
Because what Richard and Peter have just been saying is actually the perfect link into where we were, because James and I went to AMU, which is the other side of the coin from the work which you saw at the hub. And we had the extreme pleasure of being shown around by Joe, who's the clinical lead for the AMU, who deferred another meeting when we arrived in order to show us. And the first thing I want to say is his enthusiasm and vision and strategy is exceptional. And we are immensely fortunate to have recruited him, because he's got these great ideas, but he's also enthusing his ex-colleagues who may potentially come and work for us. Ah, there we go. And it does show how, how much of a people business we are, actually. AMU was really interesting because it was an environment that I'd seen before, because about 3 or 4 years ago, a relative of mine was admitted through AMU. And at that time, I would say the description I would use of the environment was chaotic. There were trolleys with notes around. There was, it just seemed to be completely unfocused. It is now calm and controlled. There's a new entrance, and it has a completely different feel going forward. There are some particular problems with the environment that I expect James will highlight. A couple of things I'd like to talk about. We looked at the whiteboard, and Peter, I'm afraid it's not working for them the way it's set up at the moment. They are having significant service interruption issues when they have to reboot the system several times a week. They are basically working around it with old-fashioned whiteboards rather than the electronic whiteboard. And that's not helping them, because then they're flying blind at that point.
Is this just in AMU, or is there a electronic whiteboard issue generally?
That's the first time.
It's the first you've done.
Yeah, I think my perception is that there seems to be a local issue on tutor read, which we need to look into.
But, we've talked about how important getting those electronic whiteboards up and running is, and they've got little other whiteboards around it that they're scribbling on. The environment's still very cluttered, and the biggest issue they have is nursing numbers. But what we were thrilled to see on the notice board in the doctor's section, was your personal phone number, Arlene. And I don't know whether they've ever phoned it, but there's a big sign up there which says, this is Arlene's phone number. So it's great to see you leading from the front on that. But, I mean, and we also heard about this improved patient flow. And so I'm sure James would like to talk about more of the clinical side of it.
Thanks, Elizabeth. Just a few things to add. Whilst there have been significant improvements in the environment, I think there's a long way to go to make it feel like a purpose-built clinical area for acute medicine. It's still an odd layout. It's still cluttered. I agree with you, Elizabeth. It's better than it was a year ago. Joe highlighted there aren't adequate changing facilities for the nurses. There isn't a relatives room. We've still got lots of cluttered equipment dotted around. And I just echo the comments that Elizabeth made about Joe Wang, and he's clearly got a vision and a passion to develop the acute medical service, and he's bringing along and attracting some really high caliber doctors. So that's really positive. He felt that the biggest challenge delivering the best quality care on the unit is actually the nursing levels. And he was recognising how hard they worked, but the challenge is ensuring that they've got the right level of nursing care. And in terms of the ambulatory care unit, he's got a fantastic vision for how the medical team can support the emergency department. And I think he was on his way down there to be the consultant of the day, to sit in the ambulatory care unit and to see people in real time as they came through that service, and also to reach into the emergency department to provide more medical support into the emergency department. So it feels like it's work in progress, but there's still a little way to go to make it feel like a really truly functioning unit.
It's such a busy unit. There's 44 beds there on that unit at the moment, and they have 15 admissions a day and 12 discharges and 3 people who are discharged to other parts of the hospital. So it's an incredibly busy turnover.
Just a couple of other comments. So the whiteboard wasn't working, so the team couldn't do their whiteboard round, but the therapists were there putting sort of dots on a workaround manual board, but they'd identified 5 patients that they could identify as a priority for early supported discharge. And there was a lady from Mighty who'd identified the patients that were earmarked for discharge so that she could have personalised conversations with them to check on their transport home and whether the environment felt clean and they got the right food. So that felt like a positive patient experience for them.
Thank you very much, Elizabeth and James. Richard?
Yeah, sorry just to intervene briefly here, but I hope I'm not going to embarrass anybody here, but at the last 15 Steps challenge when we were at St Helier, Trevor and I visited a dreadful overflow ward, and I just wondered if we could get an update as to what the status is there.
So, you have to put in my... Normally I don't need it. I think it was absolutely a fair challenge. Trevor and I walked around it that afternoon. We closed that escalation area about 2 hours after board, and one of Trevor's team went in, I think, from the Monday afterwards. So it's now been repainted. The areas that needed repatching have been patched. It's been done in much brighter colours, so it's not a sea of magnolia. The one thing we've not been able to repair, because the fault is in the walls, in the pipework rather than in the shower head itself, is the first shower. But there are 3 working showers, 4 working loos. And it's probably a testament that we've actually used it as an escalation area, so it's not just become a standard ward. We've opened and closed it 3 times since we walked round a month ago, so I think we're using it in a different way. It's supported by Flo, and Trevor's team have done an amazing job refurbishing it so quickly.
Thank you.
Thank you. Yes, I was just about to ask exactly the same question, because I think it really brought home to me the value of the 15 Steps programme, because it does mean that we can take quick action if there's something that's seriously wrong. Today I think I got much better feelings from what everyone has talked about. I mean, obviously little issues about whiteboards and so on, but I think it's positive generally. But it's always important that we stay absolutely on top of it. So we'll be continuing with all of these. I'm glad to know your phone number is it in all of them?
Yeah.
So your phone is constantly ringing.
It's in very
Good.
big letters, Ali.
Yeah.
Very big. Thanks.
Let's be numbers then.
Right, well, let's quickly start the board meeting formally. Welcome, everyone. We have a few apologies for absence, or temporary absence. Dr. Charlton is looking after patients this morning. She'll be joining us later. Professor McPhee is also looking after patients this morning at St George's, and he'll be here about 11. And Dr. Elliott, I'm not quite sure what he's doing, but he will be coming around at about 11.
Rakesh will be here.
And Rakesh is at a very important meeting, and he'll be here around 11. So we will get some more people, but other than that, we are all here. Does anyone have any updates to their declarations of interest? And Meg, are we up to date with the new people who, such as Thursday and so on, with their declarations?
I believe we are, yes.
Sorry?
Yes, sorry, I
Yes.
believe we are, yes.
We are, good, just so that we make sure we are, good. Right, let's just quickly go through the minutes of the previous meeting. Just quickly run through those. If anyone has anything to say on them or any comments on them. So, page 1, page 2, page 3.
Wait to page 9.
All right, no, 4. I just want to make sure. Page 5, 6, 7, 8, and 9. Thank you. Right, we'll take those as the record. Chairman's update. I always like to give an update, really, of what's happening out there in the big wide world of the NHS. As you all know, NHS, our regulators, NHS England and NHS Improvement, have merged themselves at the top level. They've just announced the new structure. This is all a little bit sort of, it's not excessively relevant for the day-to-day care, but it is actually very important for us because a new person is taking over as essentially the head of NHS London. He's a man called Sir David Sloman, and he's currently the chief executive at the Royal Free up in Hampstead. And he will be taking over, I think, officially on April the 1st, but probably unofficially a little bit before that. So it means that the person to whom we have always reported and has always been our link with the regulator is actually leaving. So we will have a new journey to go on with the new person. It's highly likely, although it's not been confirmed, that he won't be able to deal with everything for the whole of London. He'll have to have some deputies in the various regions, and so I would imagine these will align with the STP region. So I should imagine there'll be a new person for South West London. We don't quite know who that is at the moment, but they'll be very important as well. It's also, I think, interesting that they are putting together the new 10-year plan, which you may have seen on the news. It was meant to have been launched about a month ago, but it is I'm afraid it's a casualty of Brexit. The Brexit process is taking up all parliamentary time, and they can't find time to give the NHS new 10-year plan the time it will need, because it is going to be a very important event. However, we did have a meeting last week at which the new chief exec did outline where they've got to with the 10-year plan. And I think that, with all these things, the importance is in the subtlety, it's in the detail. And it does seem to me, and I think to others, that the NHS goes through arcs, doesn't it? And we can say we've been here before. And I think we're just coming out of an era where individual trusts, and foundation trusts particularly, had a lot of individual control and felt very much that they were in charge of their own local destiny. So we have individual trusts and individual CCGs, all of whom are quite small and working very much for the local community. I think that if you go back 15 to 20 years to the time of the South West Thames Regional Health Authority and all of that, there was a different model there where it was far more sort of central directed. And I sort of feel we're going back towards that. I think the era of the individual control, as exemplified by the 2012 Act and the Lansley reforms, is probably coming to an end, and I think there will be far more cooperation and collaboration at regional and sub-regional level, which for us means South West London at one hand and Surrey and on the other hand. So I think that's important to, just as a nuance, but it's going to be important for us is to see how much more we are going to be encouraged and directed and cajoled to work very much in collaboration with our colleagues in South West London. Which leads me on to let you know, and I'm sure you may have picked this up, that the Chief Executive of our neighbouring trust, Kingston Trust, is leaving to become one of the 7 new regional directors of the NHS. She's going to take charge of the East, based in Cambridge. So that's going to mean change at Kingston. They'll be recruiting a new Chief Exec over the next few weeks. So that's also going to be interesting for us. I suppose the other big message that I took out of what we did last week was a clear emphasis. I mean, obviously the NHS has worries at the top level. There are always worries. They're worried about money. They're worried about clinical issues. But I think if I was to say what's the top worry of the top people at the NHS, it is about people. Not the quality of people, but the number of people and the availability of people. And I think everybody is very, very concerned. Obviously, we managed to shoot ourselves in the foot somewhat by deciding to Brexit. I mean, depending on you obviously everyone has their individual views about Brexit, but what it clearly has done, without any doubt, has put off a large number of European clinical staff, particularly nurses. We had a large number of Spanish-Italian nurses a couple of years ago, and pretty well all of them have gone now, and that's the same for all the other trusts.
That's not a Brexit point.
I know it was the drop in the pound.
For us as a trust, that's not to do with Brexit. I think you're right. There are national issues, but applying that to us, Brexit wasn't the driver of the Spanish and Italian and the Portuguese leaving us in the numbers that they did.
What was the reason?
So the principal reason is that it's country specific. So for example, some came to us, got the training that they needed, and returned home. So and others came to us and then moved on into other London trusts. So using us as a stepping stone. So I think, Lawrence, you're absolutely right. It is a driver at the national level, but we haven't experienced it in quite the same way. The drivers were more local. So I think that's an important point it's more than a subtle distinction, is that those weren't the issues that were driving some of those to leave. Clearly some of our staff will have had concerns about, is Britain now a welcoming place to be and raise their families, and I think that has had an impact, but that's at smaller numbers than the headline. The headline numbers are very large nationally.
It may be not the right time to move too much off the point, but it does naturally lead into talking about NHS at the top and their responses. They did respond, other trusts clearly had a different experience, but they did respond to that loss of European nurses by relaxing the Category 2 visa quotas, which had previously prevented us from recruiting nurses because the national limits were reached and there was a block on it. I wonder what plans there are to increase that now that it's possible. And we've noticed in particular a lot of other trusts are advertising very aggressively. For instance, Imperial have been advertising in Philippines. So.
So the visa thing didn't really affect nurses. The visa thing was mostly a doctor issue. The issue that we had from a nursing perspective was the NMC, and that was relaxed last Friday. As the language, and that was the big factor for us, because while we can get, even the nurses that we could get over, they just couldn't get through the language test of the NMC. And I'm talking about, nurses who had done their PhDs here in English couldn't pass the English language test. So the NMC have now relaxed that, which will, I'm sure, which will help, because it means that even some people that have done it a couple of times and they were at the 6.5 instead of the 7, we will manage to get onto the register. So that's going to be great. And I think in terms of recruiting overseas, we are looking at that as part of our recruitment retention. I think for us, the big thing right now is to retain what we've got, because we're managing to recruit still, but we're not managing to retain. And so the work that we need to do is about retention before we start bringing more people in. Although we're not going to stop bringing people in, but we need to focus on retention.
Good, thank you. I mean, I'll wrap up my introduction now, just by saying that that's a really interesting discussion, and I think it encapsulates what's going on at the moment. At the top level, there is a lot of concern, a great deal of worry about numbers, both nurses and doctors, and there was sort of, no one actually came out and said it, but it just was sort of there all the time as an emphasis. Anyway, that's from me, Daniel.
Thank you, Lawrence. So I was in the meeting with you. That they had two top risks. The first one was workforce, and the second one was capital. So just going to my report, I think the place to start is a place we don't often talk about, which is planned care. And you will have seen in the news this week that the NHS total waiting list has now topped 4 million people. We're bucking the trend, so our waiting list is less than it was at the beginning of the year. We've got 750 people less waiting more than 18 weeks than we started with in April, and that is despite a 4% increase in referrals to Epsom and Helier. So planned care is doing good things. We haven't sussed it in every specialty, but in quite a few, the waiting times have come down a lot. So thank you to everyone involved in that. On the Brexit front, we have agreed to pay for the costs for all our European staff, of whom there are 495, to have their, whatever the application thing is called, and that's gone down well. We celebrated Black History Month in style on both sites. Arlene did a great talk all about Arlene and your career, and Dr. Rahman spoke about his career too. In terms of the flu vaccinations, we're doing really well. We have the second highest staff vaccination rate in London. We almost have achieved the target of 75% of staff having actually had the vaccination. We made a little video with some of the children from the nursery, which was really well received all over the place. Jeremy Vine even tweeted it. There's a section in the report about the sheer quantity of estates work going on, and I really was just looking back at it. Nearly all the photos have now moved on. So there's the photos of the building works going on in A&E. Well, you've now seen it open this morning. I popped up to outpatients on this site yesterday. It's almost finished, isn't it? Yeah. So when does that open?
Patients from there, I think, from the 14th of January.
Wow. Henry Marsh, the famous neurosurgeon, came to open the surgical assessment unit yesterday. So there's a picture. There was 1.70 builders working in the space to get it ready. So that was a big success. Then there's a thing about us replacing lots of our beds, and it was a bit ironic, really, that the weekend before I'd been in Bristol, and we went into a behind-the-scenes tour of a museum in Bristol, and they were and I said, "Why have you got this King's Fund bed, and they said, well, because the hospitals in Bristol removed them about 5 years ago, and we wanted one for the museum. And I was thinking, God, we still have them in operation in Epsom and Helier, so it was very good to see that this huge new arrival of beds. Then, in terms of the teams doing well, the maternity team have got gold baby friendly from UNICEF. It's the only, well, I think, the only hospital to have it reaccredited on both sites in the country. So we celebrated that. Stroke services. So on this site, they have been fragile for a very long time, and we were doing very badly on the national scoring. But in the last quarter, we achieved a B. Which was actually better than all the other hospitals in Surrey other than Frimley. So that's really good news. We've reported before about the changes we made to prostate diagnosis with a new pathway called RAPID, and the team won the Health Service Journal Award for Acute Innovation for it. The hip fracture unit, once again, was top performing unit in London in the league tables. And then we've had an awful lot of people coming to visit for various things in the last few months. So the CQC reappeared to do an unannounced visit, mostly on this site. We've had verbal feedback that was broadly positive. We haven't had a formal report yet, but we're not expecting to hear too many negatives, because I think if we were, they would have told us already. The National Patient Safety Agency came to visit to talk about how we do mortality reporting. A new non-exec director from NHS Improvement came to see Epsom Health and Care and was completely bowled over. He's a doctor from America who's been brought in specifically by NHS Improvement to lead on their integrated care work, and he said, what you've pulled off in Epsom is everything that I have always wanted to do in Boston, and you've got further than we have. So he was very happy. We featured on the Sunday Politics show because Siobhan McDonough, the MP for Mitcham and Morden, was one of the guests, and she wanted to talk about Epsom and St Helier, so the BBC came and filmed us, and then that was one of the centerpieces of that politics programme. The comms team have decided that we could communicate better by making a podcast, and the media picked that up, and it was the first one was a great story about a very famous skater who had a bit of an injury because he wasn't wearing a helmet, and it was all about how he was going to wear a helmet in future and the great care he had received. And then loads and loads of amazing staff who we've given awards to, either because they've been nominated by other people in the organisation or because patients have said they have been great. So there we go. Wave 4. Oh yes, well that's not in here because Wave 4 only came out last week. So Wave 4 is the national capital allocations that they very quietly announced because they couldn't do it because of in the Commons because of Brexit. So it just came out as a series of letters, and we have received £7.5 million to enable us to move the new Epsom and York Community Hospital from West Park to Langley Wing, and that means we will be part of a massive redevelopment of Langley Wing, which we will start in 2019, and I think will take a year to rebuild it. And it's going to be amazing because it will have all of our rehabilitation services in therapies, beds and stroke all in one place. And we should be able to make a complete national centre of excellence for rehabilitation as a result of that.
Yeah, Daniel, could I just ask you to comment? I'm very conscious that we hear on the news about unsustainable levels of bed occupancy nationally, escalating waiting times, ambulances being turned away. I just wonder whether it might be helpful to have a quick briefing on how we stand as we head into the sort of the depths of the winter months.
So on one set of the measures, it's really very positive. So it is quite unprecedented for us to be in the middle of December and at St Helier have 2 wards closed because we have so reduced the length of stay for the long stay patients, the super strandeds, which is what Dan is showing. So we started the year in April with about 180 patients waiting more than in a bed for more than 21 days, and we're now down to 120.
We hit our lowest level ever 2 weeks ago.
So that's an incredible achievement, which is down into two things really. The big changes in the way medicine is working on both sites to get decision making better for patients more quickly, but also it's a fruit of all the integration work we're doing with all our partners in both communities, that the people who need to be discharged with support, we're finding it much easier to arrange the support and get people back into their homes. So that is a big positive. So on the bed capacity issue, I feel much more confident this winter than I did feel this time last year, when it was already completely impossible.
So what does that mean in terms of percentage occupancy? I think the national statistic was something like 94% last night.
So our percentage occupancy it hovers 2 or 3% either side of about 85%. But you have to bear in mind that all that includes everything, including the EOC. It includes our surgical day beds. It includes our endoscopy day case beds as well. So when you start looking at our usable medical capacity, which isn't what we're asked to report on, it's a bit tighter than that. But the figure they're basing that is 94, which is why it's so serious.
Yeah. But there are two big problems that are, in a sense, new. So the first one is this has been the worst year so far, if in recent living memory, for children being really ill with bronchiolitis, and the sheer volume of children we are trying to admit, it has caused huge pressures everywhere. So Ruth, who's the paediatrician on take this week, on Monday we have 16 inpatient beds on this site. She had 25 admissions, had no idea how we were going to make that happen, and in the end we had to open another part of the hospital for children. That's quite difficult because we don't have a surfeit of qualified children's nurses and doctors. We had to take patients. A lot of children inpatient admissions are going a long way out of southwest London to find a bed. So that's been going on for weeks. So it wasn't just like a 2-week issue. I think we've had 2 months now of a huge number of sick children in the system. So that has had a big impact on A&E performance, because if you don't have the flow in children's through the A&E into the wards, they end up in A&E. And the second issue, which we're going to talk about more in the private part of the board, is we have some big staffing issues in A&E. And whilst we now have the space much better in both the departments, recruiting sufficient people to provide the care is quite challenging, and you can see on the sit reps that we look at every day the vacancies in nurses and doctors in A&E and all the huge amount of juggling that's going on to keep both the departments safe. So it was very exciting that we recruited 3 new A&E consultants a couple of weeks ago, and it was really exciting because they were all doctors who were qualified overseas, and then we had trained them up, and they said they wanted to come and work at Epsom and Helier because the training we had given them was so great, and they really liked the leadership in A&E. But actually, we still end up with no more A&E consultants than we did have a year ago because people have moved on as well. So I'd say those two things are really making it much harder to do well, but the capacity issues are better than they were.
Thank you. Good. We'll move on. Thank you very much, Daniel. We'll move on to the IPR. I think, James, would you like to say this?
Yeah, I'll take the first part. So the first page is, as ever, mortality. We have got a mortality paper later in the board, so I won't dwell on this in huge detail, but our mortality figures are in line with our usual expectations, with a generally consistent trend of mortality slightly lower than the national average, but within the normal range. And I'll talk about the mortality review forms later on in the meeting, if that's okay. The second page, I just want to touch on stroke. We have struggled at both sites to have enough capacity for our stroke patients to have their length of stay maintained on the stroke units. And performance has improved in recent months. And as Daniel highlighted, the quarterly audit of both Epsom and St Helier stroke units graded us as a B, which is better than we've had for a little while, and better than some of our surrounding trusts. Dr. Kakar wanted me to highlight a few things about stroke. He wants to acknowledge that the time to giving the thrombolysis, the clot-busting drug, has improved at the Epsom site through a change in process about admitting patients directly to the hyperacute stroke ward rather than being managed through the hub. So it's improved the time for decision making. There's been increased funding and changes in workflows that helps early supported discharge since April, and that's he wanted to acknowledge the huge work that's happened there. But we've got an ongoing challenge that we want to explore in terms of optimising the therapy support on the stroke units at both sites. You'll notice that VTE, for the first time probably in about 2 years, has hit the 95% mark, but I'm not sure that we've got this sustainably sorted, and there's ongoing work to improve that. On the next page, in terms of incident reporting, we are still challenged with our delayed reporting of complex incidents. We've now interviewed for 5 additional consultants to perform real-time mortality reviews and to support the incident review process. So we hope that in the next quarter we'll see a significant improvement on those parameters.
Moving on. Safe staffing. So for some reason, the one I have, the data is, it's absolutely fine. So CHPPD continues currently to be 5.2, which is slightly different to the national average. However, we are reviewing, and I know I've said this for a while now, but I think we're almost there, where we have actually got to why our data is so skewed, and we are working with NHSI to get the data correct. So I anticipate from January we'll have the correct data. The big issues in October, if you look down the bottom of the page where it says about the red flags, we have had 40 odd shifts where we had only one nurse on a shift. However, I think this needs to be taken with a little bit of insight, because in some cases one nurse was all that was needed, as opposed to they needed 3 or 4 but only had 1. So we're going to refine that so that we're able to make that clear going forward. Safe 1.6, which is healthcare associated infections. MRSA, after 272 days of being free of MRSA bacteremias, we have now had 1, although this still says 0, and the RCA has been done for that. There was a missed opportunity to swab the patient who came in with quite a nasty skin infection. So there is some learning from it, although it would have been quite difficult anyway. In terms of C. diff, we are within our internal trajectory now. As long as we continue like this, we will manage to stay within the numbers that we should. The challenge still remains on hand hygiene and bare below the elbows, but we are now working differently. And I suppose take the opportunity to introduce Sarah, who is the new Deputy Chief Nurse that started with us on Monday, and so she's going to be supporting me to do quite a lot of this work going forward. Maternity care, no new issues for maternity. The birth centre use was still down because of the work on the list. It was planned work that should still get better going forward.
big drop in cesarean sections?
Yeah, I think it's just case mix as opposed to a planned change in what we do. You know, added cesareans are done.
We had a report, special report from maternity at PSQ recently, and there is always this trade-off between cesarean sections and fetal movement, and you know, at what stage you decide to go for a cesarean, but all the figures in terms of outcomes are improving, and we were really pleased to see that a lot of those issues we were concerned about a year ago are showing a significant improvement from all the training that's gone on in the team.
Arlene, can I just point out on the maternity page, we did have one case of a neonatal encephalopathy, which is an incredibly serious situation, but there has been a detailed review, and I don't think there was any care concerns that resulted in that unfortunate episode.
Thank you. In terms of patient experience, you'll see from the Friends and Family test, we remain above the Trust's target and some of specifically the London's targets in terms of both the response rate and what people are saying about our services. So we're showing strong performance on there, particularly in terms of our A&E and patients saying that they are having a good experience through our A&E services. Always can improve, but that's a strong performance, particularly from emergency services. Positive comments, the key driver continues to be our staff, and a lot of work has been going on with all of our staff through the Your Voice, Your Values piece of work to support that piece of work.
And I need you to sign it, please. I need you to sign it. I don't care, I'm disrupting your meeting. I need you to sign this and hand it to me, please. No. Well, I'll leave it with you, Lawrence. And I have my copy, which I'll put on the post.
Thank you. So in terms of PALS and complaints, PALS, we are continuing to see a huge number of people use those services, which is a good thing. And the PALS team are coping really, really well with that. So we received over 570 inquiries throughout October. A lot of those you can see on there are for advice and information and communication specifically. The big story, I think, for the team is on the complaints. We continue to see a positive trend in terms of the timescales and responded to those timescales. But importantly, I'd like to highlight for October, the number of breach cases was the lowest we've ever seen on record, and this is where we have had to, for a number of reasons, exceed the timescale, either due to the complexity or other information coming in from either somebody raising concerns or from staff who are doing the investigation. So this is a really important measure in terms of people taking this, both us capturing the information initially properly with the complainant or the people raising concerns, but in addition to that, us responding in a timely manner from a staff's perspective, so that's really important. And the second important measure to open is the number of reopens. So this is where a person raising concerns that we've responded to would come back to us and say you haven't answered the exam question, remains incredibly low, with only 3 complaints reopened in the month. So that's showing that we're not just driving down or driving up the response time, so we're doing it quickly, we're actually doing it at a quality level.
Could I just, very quick positive point, one of the things that I really notice about visiting both here and St Helier is that even if you just hesitate for a bit, which I often do because I'm lost, somebody always proactively asks if they can help, which, you know, I guess you kind of take for granted after a while, but there's not actually many places that you do that. I think it's a great reflection of the culture that the staff have got.
Thank you.
Operation performance
operational performance. So cancer, we've met the cancer standards for September, and October is now in, and we've met that too. November may be more challenging for reasons we can come on to in a future meeting. I think it's worth reflecting that we've done that in the light of demand that remains significantly above next year. So although we're matching seasonal and monthly trends, we're still well above. I'd also highlight the continued success in urology, which Daniel flagged up, and I think the sheer volume of urology is proving a significant help to the overall trust position, but it's a markedly improved position. On overall elective care, Daniel's already highlighted the fact that our overall waiting list and our backlog fell in October. They will fall again in November, and that's slowly improving our RTT performance figures. Our median waiting time, I think, has gone up for reasons we knew over July because we were short of capacity, and is now slowly starting to come down. That's something we're tracking. And one of the things we need to fit onto this is the number of over 40-week waiting patients, which is also now starting to decline. I probably won't go into much more detail there, other than highlight the 52-week waiters, which has jumped up again. And the reason for that is there's been something called a drop-in, which is basically where you believe you've treated a patient correctly. The patient's outcomes go to another consultant and sits there on a waiting list, but is then regarded as a completed pathway. And we're doing some work in the moment in outpatients to make sure that we can try and remove those sorts of errors. It's a very small number, but it's something we're needing to track as a quality issue as much as a delivery issue. Moving on to urgent care, we had a dip in performance in October against the national trend. I think some of that is the staffing issues that Daniel's alluded to, but also the disruption caused by our building works. I don't think you can underestimate the impact of doing that. We sort of highlighted that to our regulator. It wasn't until they walked round and saw the 3-foot reinforced concrete walls we'd drilled through in resus, they kind of got the understanding of how difficult that building process has been. And we're now putting the finishing touches to the Helier site, and we've already walked around the changes that have opened here. We've highlighted the fact that our length of stay is slowly starting to drop, and more importantly, our long stay patients, the longer term trend is now substantially downwards. We were challenged to come down from 182 long-term longer stay patients to 132. We're now well below that. We're running around 115 is our working daily average at the moment, so we've really improved that quite substantially.
Could I just refer us back to the cancer access page, Dan, which is such I mean, it is fantastic to see it all green on this page. And this has absolutely come about because of a number of small incremental changes that have been made in the patient pathway, and also the big step change on the prostate cancer. And, you know, this really does show that, you know, we're working well on this particular aspect. So well done, Dan.
I think we're getting there.
Anything on electronic referrals? How's that all going? It's been going for a couple of months.
I'm really sorry because it sometimes appears on this chart, so my apologies for it not being included. So our ERS rates continue to be all within a 0.1% of the maximum possible levels of referrals. There's an agreed number of exceptions which the CCG and others are entirely happy with. Our biggest issue now is our appointment slot issue, ASI rate. We knew that by pushing to e-referral that would jump, and we're now working on measures to bring it down. In some cases they're to do with job planning, where we've set the polling range.
Sorry, can I be clear? Does that mean we're getting more referrals than we can deal with?
No. So what it means is that the GP or the referral centre, which can be an issue in its own, are sometimes either cold booking patients in, which means that our DNA rate has gone up very slightly, or it means that they are looking for an appointment, and whereas previously they would have referred to Epsom and St Helier, we would have said that's fine, there are about 4 or 5 different locations you could have your outpatient. Now they're looking for an outpatient appointment in a specific location. And for small referrals, so gynae cancer referrals is a really good example, to be able to meet every appointment I'd have to have about 20% spare capacity in each location to be able to meet the variation in demand. Whereas previously you'd have been referred to one referral hub, we would have phoned the patient and we would have slotted you into the next available appointment. So there is something about The advent of patient choice, which is a really good thing, is forcing us to question the balance between what we can make available in resource terms and whether we've got our planning right. And in most cases, it's a combination of the two. And we're now going through with each clinical area, specialty by specialty, about how we can improve that. So it's quite a complex beast. Thank you.
Dan, can I ask you a couple of questions in relation to urgent care? The first is, on the first two charts, the 4-hour performance and then the breaches for the minor A&E performance. Those are obviously October stats. Do you know what the November position
So
is?
the November position will be broadly comparable. The issue with minors, and it's something we're going to in private board, and it ties to a comment Daniel's made, is about the numbers and resilience of our UTC treatment pathways. There are some staffing challenges, particularly on the Epsom site, in terms of our ability to deal with that. And then when you match that to the available middle grade gaps as well, that's the next cohort who would normally have gone to support that pathway. So there have been some issues there.
And then my second question relates to ambulance arrivals and handovers. Again, this is supposed to be October data, and we haven't got data for large parts of the statistics for that.
No, so the October data is the Epsom part is the part that's missing, and we're reliant on the CCAM giving us the figures because they send us the note, we validate it, and they submit an agreed position. And what we don't have is that data yet from CCAM. So we will get that, and I can backdate it when it arrives.
Do we know what the trend is?
Broad stability is the honest answer. Again, we can cope with the numbers, but there are some days where the numbers arriving, they cluster together, and that overwhelms us, and then you end up with a backlog that you're trying to catch up with. So there have been a couple of days in the last few weeks. The norm is about 35 to 40 a day here. We've hit 45, even up to 50 in a couple of cases, and Epsom just can't cope with that.
Thank you.
Okay. We've talked a lot this morning about the vacancies, and whilst we're still above our KPI target, we are moving in the right direction. There is continuous ongoing recruitment into our critical roles. In a couple of months ago, we set ourselves a target to recruit 100 HCAs, and to date we have recruited 63. A few are still waiting to be allocated places in the organisation, but we are working to progress that to cover our winter pressure periods.
Debbie, can I ask, will they be in place for the winter period? Because I know there's an issue about, we recruit them, we select them, and then they don't actually get the wards for a while.
Yes, and that's correct. We are working with Arlene's team to ensure that we do get them placed as quickly as possible. They are checked and they are ready to go.
Yeah. So we have 45 that will be in post by the 7th of January. So, and the rest are being processed.
In addition to that, as Arlene mentioned earlier on, we are in the process of rolling out our recruitment retention program, working alongside NHSI, and that we'll be doing that for the next 3 months. And the end result of that would be a robust retention plan, which will be monitored by NHSI. The other areas I just want to highlight is that our sickness absence rate is quite high, and we have a lot of work to do around that. And I would imagine that relates to the pressures that the staff are under, particularly with our vacancy levels. And then finally, we are focusing on working on our improving the way we support staff to complete appraisals, and that has meant us reviewing our systems, and with the system we've got, making it as user-friendly as possible, and that's work that's ongoing. Thank you.
Just to highlight a couple of things, we had over 45,000 people, I think it's amazing, visit our website for information, particularly looking for general information, but a lot on vacancies and maternity, so they're really continue to be really important in terms of promoting and supporting our services. And then a lot of you will have seen we're just starting to roll out, not all of the board have got them yet, but they're on order, our bright yellow name badges, and that caused a lot of fun through Twitter, a lot of people supporting that. Originally, when we put them in place, there was a bit of nervousness from some staff and from some patients, but the feedback we've had from both patients and staff has been overwhelmingly positive, so it's a really good move. In terms of having our name badges, and this is specifically done for ease of people being able to read them, not just for people who either have dementia or short-sighted or have sight issues, because our other name badges are a bit difficult to read, so we've had very positive experience from that.
Thank you. Next is finance. So Richard or Dan? Richard?
Happy to make a few comments. I think what Rakesh will probably say here is that the core income and expenditure profile has remained very much on plan, and huge credit to the team for achieving that. I think where the pressures really begin to build are through the next quarter, where typically the cost improvement program challenges really kick in, because a lot has been achieved already, and there's a lot which remains unidentified. In terms of hitting the sort of broader control total, in the absence of hitting the core A&E targets, we fall short of some of the additional funding. But as I say, I think that the core focus remains on the underlying operational performance, which, as I say, through the first 3 quarters has proved to be pretty much on plan. As far as the capital programme is concerned, everybody's aware of the huge capital programme that's ongoing. A lot of work is undertaken to review where we stand in terms of delays. Broadly speaking, I think substantially all of the projects are broadly on budget, although there are some delays associated with just the programming of some of that work. It's likely that we won't achieve the full capital programme during the course of this year, but I think we're going to be much closer than perhaps I'd anticipated at the beginning of the year. So again, credit to Trevor for that.
Thank you very much, Richard. So that's the end of the IPR. Oh, yes, negotiations for the risk register. Did you do that?
Yes, so the risk register was fully reviewed at the last Performance Assurance and Risk Committee, and as a result of that, there is one risk that has been around for some considerable time around out-of-hours interventional radiology has been a concern. The principal concern was not that there was a process, but it wasn't formally agreed and with the robust enough arrangements in place. That has now been formally agreed, and so the Clinical Services Division are satisfied that we have robust arrangements in place, so that risk is now being de-escalated, but that's taken sort of pretty much 18 months to get to that point. So that's one piece of good news. There's then the next section talks about new risks which are related to how we manage laboratory processes, particularly around blood products, in relation to learning, the kind of immediate learning from a recent serious incident, and that means that the division are scrutinising a number of practices and processes that we need to review, and because of that there is an escalated risk there that we need to take further action to ensure that there are more robust arrangements in place. So there's an additional risk for that. The next area of the report is more highlighting areas where things are under review and have been on the risk register for some time. So, for example, the delays in communications to GPs, and we've just talked about the cancer performance, whether both of those risks are now sufficiently under control that they should be de-escalated for a period. We've also talked about flow and capacity and performance in ED, and we need to do some work to better reflect all the mitigations we have in place and to ensure that there are further actions in train. So that's further work in there, but those are the key components of the risk register.
Thank you. Is there any idea how long it's going to take to sort out this blood transfusion issue?
I think Ruth is leading on that, and perhaps we can pick that up in private report.
Okay. Thank you very much. Richard?
Yeah, dare I raise the topic of Brexit, but have we had any specific instructions around risk management in the context of a potential hard Brexit?
Yeah. So, again, that's a paper for private board, but the Department of Health has issued a no stockpiling order, and they are assuring us that they are working with their suppliers so that they have 3 months supplies available and a further 6 weeks with the manufacturers. But we've been specifically told not to try and make local arrangements because that will disturb the current flow. We can pick that one up later.
Okay. Right. That's a bit. Anyway.
So the letter that Matt Hancock wrote to us all, is a public letter, so we can share it. And you can read into it what you want. But the message from the Department of Health and the Secretary of State is very clear about what we are and aren't required to do for Brexit in the event of a no deal. One of the requirements that we were told was you must take to your trust board your emergency planning processes and an assurance that you know how to run business continuity, and you'll see that that's on the agenda. So,
yes, fine. Thanks. I mean, we did have quite a long discussion about this last week at our chairs and chief executives meeting, and interestingly, the general feeling of the people I was with wasn't so much, will the drugs be there, because clearly arrangements are being made. It's much more about, particularly in southeast England, will the roads get jammed up with lorries and how the ambulance is going to get through. It's more sort of basic stuff than that. So there we are. Anyway, hopefully we won't get there. Right. Thanks very much. We've now got all the board committee reports, but in the interest of time, I'm not going to ask anyone to go through those, but they are there for people to read. So let's move on to 3.2, which is the mortality peer review, which was a Ruth thing, but James, would you mind?
Of course, if I can get my IT to get the paper up. Just bear with me. No, it's okay. It's fine. Thank you. This paper covers the requirement that we present to board the progress that we have made as a trust in the important matter of learning from deaths. So we aspire to undertake what's called a level 1 review of just about every patient who has died within our trust, and then select patients that are fulfilling certain criteria to undertake a much more detailed structured judgment review. And the types of patients that we should be performing a structured judgment review include any of those patients where carers or those who are bereaved have concerns about the care, whether staff have any concerns about the care, whether there's a patient with learning disability, or if there's an unexpected death. I think it's helpful to have a look at the dashboard. The important things I think to take from this dashboard partly is that we are still in an early stage of ramping up our internal processes and the numbers of staff that we have available to perform the structured judgment reviews. you can see halfway down the table about the patients who have undergone a stage 1 review has increased from 43% in quarter 1 to 52% in quarter 2. And we have interviewed for 5 consultants to spend a day of their working week. So that's basically a full-time consultant equivalent to try and do these reviews in real time. And we expect these numbers to improve very significantly as they come into post in quarter 4. These consultants will also be able to help with the other areas where we've been challenged in terms of timeliness and detail of incident reporting and investigation. We still have relatively low numbers of patients where we have completed the stage 2 structured judgment review, and those numbers will definitely increase significantly. At the bottom of the dashboard, a judgment call has been made as to whether we often identify elements of care concerns when patients have been through our services and have unfortunately died. But we identify between 1% and 2% of cases where patients have died where the care concerns are such that they might be listed as potentially avoidable. This is in line with national average, and the Royal College of Physicians suggests that nationally they would expect about 3% of deaths to fall into this bracket. So we're in line with national average, and I'd have concerns with the quality of our review process if we were a very low outlier, and I'd also have concerns clearly if we were a high outlier. And it's important that this is followed up through the Patient Safety and Quality Committee. So we've undertaken through this year 83 structured judgment reviews, and 10 of these cases have resulted in the new identification of some care concerns. They've all resulted in incident forms being undertaken and a more detailed local investigation. And some learning themes have arisen from these cases that have either been fed back locally or through the structured divisional quality meetings. And so for the organisation, we've identified areas where we need to improve our practice, and we've set up working groups to look at how we administer intravenous fluids. As Elizabeth and myself were identifying on the ambulatory care, the acute medical unit today, whether we've got an opportunity to cohort our sickest patients who don't fulfil the criteria for being looked after on the intensive care unit. And we've also looked at refining our escalation policy to try and identify the right patients to go on escalation wards and ensure that we have the right checklist so that those wards are staffed appropriately and de-escalated at the earliest opportunity. So I think I'll stop there and invite questions.
Questions or points? I mean, obviously,
yes, I mean,
said that it should go into PSQ.
well, yes, it will do, and indeed we've seen this report in PSQ. And I would also like to refer back to a visit that Daniel referred to, which was Suzette Woodward from NHSI. She's the quality lead, and she, as well as giving a talk to a large number of staff, she helped with a workshop on how we do mortality reviews and RCAs in order that we can do this more in real time. And there is an enormous amount of work going on to try and bring the strands of learning together, because this is, you know, we talk about this a lot, but actually nobody is terribly good at this. Things happen and then they happen again. And they're never identical, but they often have some of the similar causes, and these are the things that we really need to get to the root of. And it is really difficult. It's really difficult to learn lessons and keep them learned. And this is something that through the mortality reviews and the SI process and looking at lower level incidents is something that we are trying to do, and PSQ is working to monitor what is happening.
Thank you. Let's move on then to the quality account.
So I'll pick this up too. So the Trust identified at the start of the year, in association with our stakeholders, 6 priorities for improving the quality of care that we offer our patients. So this is a progress update for Q2 on those 6 areas. The detail is there in the paper, but I'll just highlight a few areas. So the first quality priority was to increase the proportion of patients seen daily by consultants when they're inpatients, and I think we are genuinely making good progress on this. The 7-day standards assessment suggests that over 90% of our inpatients are reviewed at least daily by a consultant if clinically indicated, and all of those patients where a review is indicated at least twice daily are managing to receive that review. We're currently in the middle of a job planning process where we are looking to improve the quality of the job plans to free up consultants' availability, to provide more inpatient care, to be available to perform the whiteboard rounds, and we're looking at business cases to optimise the availability of our general surgeons and trauma and orthopaedic consultants to be more available on the wards. The second priority was learning from avoidable deaths in the hospital, which we've just touched upon in the last report. So I won't go into much more detail on that. The third priority is to improve the recognition and management of sepsis. This is a national priority, and our data suggests that we are doing very well in the emergency department. We're doing quite well on our general wards in terms of early recognition of patients with sepsis and timely antibiotic therapy, and we're in the process of appointing a new clinical lead to support and embed the learning across the organisation. The fourth priority is to work with our external stakeholders to reduce potentially avoidable admissions and readmissions, and we've heard a lot about some of the fantastic work that's happening with integrated care, both here at Epsom and the newly developed Sutton Health and Care programme. The fifth priority is to enhance the patient experience in the emergency department. We know that whilst the response rate for friends and family tests in the ED is very good, we're a little bit below the national average in the reported friends and family score in the emergency department. Healthwatch Sutton and Merton have very helpfully supported us with a survey of the patient experience, and the details and the learning that we can get from this is highlighted in the report, and I think this will form an action plan that we can move forward with the patient experience in the ED. But some of the themes that come through relate to how do we communicate with patients who are waiting in the ED, sometimes for longer times than they would like, and they see people who come in after them who are being seen before them for what we think are good clinical reasons, but we don't communicate that well to all of those patients waiting.
Do we have big notices which say that sometimes people who come in after you will be seen before you? On public display?
So we do have some of those notices, but clearly we need to look at multiple ways of communicating with people who are waiting.
Can I just add to that? One of the things that we're looking at is how we produce a video to help explain to anybody in the waiting room about the process. So it's more about the journey. So you're right, we can do more to raise awareness, and that will be part of this action plan that we're working with Healthwatch on.
And I think there is a national concern about how do we accurately convey to people who come to the ED what the expected waiting time is, because this does have implications, and how we do this in an accurate way, we still got work to do. And the final priority that we identified was strengthening our involvement with carers and caring groups. So we are working with local carers groups. We've undertaken a baseline audit to help us guide areas for development, and that will be outlined in the next quarter's report.
Thank you. Any other comments on quality care? Thank you. Dan, emergency plan.
So I think the paper largely speaks for itself in terms of we've been substantially assured externally about our readiness for emergency incidents. I think I would highlight that whilst they have noted that we have not conducted the exercises that we would hope to have done this year, in part because we've managed to gap our emergency planning manager over the summer, we have conducted several real business continuity incidents and played part in the London tabletop mass casualty exercise. So I think we can say we've rehearsed some of our procedures even if we've not done so formally. I'd highlight the Epsom lift failure as probably a particular example where we rolled out a full business continuity, had to do the planning at various levels of command, and that ran for about 36 hours in terms of the risk we're managing across estates, ops, clinical practice and our staffing. So I think we've given ourselves a reasonably good rehearsal. So the assurance is there, and there are 6 domains which are reported in terms of the things that we still need to work up. I think my concern is we probably need to, as well as running Brexit-specific planning, we probably need to dust off and rehearse a couple of our plans and have a talk-through of the things that I'm actually worrying about, which are more about shortages of fuel, people's ability to get to work, those sorts of incidents, which we absolutely have contingency plans for. But I think it's worth rehearsing those and making sure that our senior leaders are aware of what is expected of them in each of those. And I'd prioritise that ahead of trying to roll out a specific CPRN incident.
How many business continuity incidents do we have in a typical year? I mean, I know we had the lifts, we had the floods and so on, but how many typically, or is it hard to say?
You know, I don't know the answer to that question. I'd have to come back to you.
I don't know exactly, but I'd say we're at least 5 a year.
At least 5 a
typically,
year.
yeah.
I think it's worth putting this in perspective that if you had buildings that were fit for purpose, you wouldn't be having these business continuity incidents. So I think it is quite rare to think that your business continuity plans are supposed to be about events that happen outside the hospital that you have to respond to because you end up with a lot of patients. I can't remember the last time we had one of those. They're nearly all because we have an infrastructure failure in the hospital, which puts our patients at risk that we have to then contend with. So we've got a new fantastic emergency planning lead, and I had a one-to-one with him, and I said, I think the thing that we need to work on absolutely specifically is for every clinical area, we need a plan for you if you can't run your clinical area because of something that has happened in the infrastructure for it. Because we're getting it so regularly, and we're getting better at it all being codified, but actually we need a structured manual that is codified by department. But that's still a second order issue onto the issues that we definitely now need to think about if there is a no-deal Brexit, what does that actually mean? So that's the definite next quarter's work, and then we can get on to.
So from business continuity, our time is being focused on Brexit issues around our suppliers, suppliers equipment, some of our large sort of contracts as well that we're with people that might, the main companies might be outside of the UK.
And I won't rehearse the conversation we're going to have in about 2 hours in private board, but I don't want to underestimate. There are things we can do as a trust. My biggest concern is not those things to do within the trust, because I think by and large it may be tight, but we can probably manage. It's our reliance on external people, particularly social carers, and there's a large quantity of those who are non-UK EU citizens working in our areas. And if many of those were to return back to their place of origin, we may find ourselves finding a shortage of social care in the system, and that may have a far greater effect than anything that happens internally. So they're the things I'm worrying about.
Thank you. Thank you, Dan. Right, let's move on. Contracts over 50,000. Daniel, do you want to do that as Rakesh isn't here? I don't think there's nothing of any unusualness there. Does anyone on the board have any other business? In which case, thank you very much. That's the end of the meeting. We'll just got a few minutes left, so I'd like to invite any members of the public who have a question to go ahead.
Thank you, Mr. Chairman. I've got two questions actually. One's on the blood testing here at Epsom. I think there are some 6 trained phlebotomists doing it at the time, and yet there seems to be given priority to those coming from clinics who actually get priority over those who've got a ticket and have been waiting. And yet the ones coming from the clinics aren't actually going to be seen that day by obvious results, because clearly the results aren't through. So I'm just wondering why people coming from clinics are being given priority. There was a fast track lane.
I can't answer the question. I know there are different categories. There's your standard outpatient clinics, and there's also hot clinics, which are designed to keep people out of accident and emergency. So there may be nuance in that particular clinic was prioritised, but we'd have to check the detail.
There's rationale for it. It's just that it's very upsetting for somebody who comes in, they're sitting there, they've got a ticket, and they think they might be in and out within, say, 40 minutes. Meanwhile, there's a host of people coming from clinics, they're getting priority treatment, and you're sitting there an hour and a half. It's happened recently.
Okay.
I think some clinic, the results will be available on that day, so they come because they need the results. But it might be that we need to look at how we do stream it differently. Yes. Yes.
I think that would resolve a lot of potential resentment. And the second question is to the chair. I actually have recently been involved in quite a lot of stakeholder reform group activity, and in the process of that, stakeholder reference group activity, and I've met David Clayton Smith, who I'm sure you know is the head of Sussex, who's now stepping down, but I think he's also running the programme for the consultation for the 3 CCGs. And one of the questions I put to him was the odd one about the fact that these meetings are out of after the trust board is closed. I recognise that, so they're never minuted as such. And I said to him, is that your normal process in your trust? He said, no, not at all. We always minute what is said by the public and include that in the meeting. And I'm just wondering if the board would like to consider doing that for next year, because it is always a slightly anomalous situation that none of these comments from the public are ever reported. And it seems as though you're trying to avoid picking up points that the public are making. It's just a suggestion for you to consider.
Well, I do know David, as he said, and I'll talk to him about that. I mean, clearly, first of all, it's all filmed. So there is a record of it. Yeah. It could be one of these sort of custom and practice things. We've never done it, so we haven't done it, if you see what I mean. I'll talk to David and I'll talk to him about his role, if you like, in representing stakeholders, as to what he believes good practice is.
I'm just putting that on the table.
No, okay.
To consider.
Thank you.
And finally, I would like to say one other thing, which is actually generic. When you look at the volume of papers and the work that you guys are doing, it's amazing that any of you have managed to get to treat the patients. And I'd like to congratulate you enormously on the way you've actually been able to operate the trust this year. I wish you a very happy Christmas.
Thank you very much. Good to see you. Thank you very much, Nigel.
Can I ask Daniel a question? Excuse me. How are we getting on with the sale of land at Epsom? Going to be done?
So it's in progress. We are hoping to complete it for the end of March. There was lots of interest. One of the things that we committed to the public when Mr. Grayling was in the room was putting the results of the independent report into, if we did sell the land and the system decided to build a new acute hospital at Epsom, could you build it? We should be able to do that in public in January. We need to find out more, perhaps February when we next have a public board. So that will be a helpful piece of evidence. But it is progressing. And I am confident we will be able to sell the land. And confident that we'll be able to also say that all the money that we get from it will all be invested on the Epsom Hospital site. And the array of projects that we would like to do on this site is just enormous. So we will definitely make very good use of the money when we have it.
Could I make?
Oh,
sorry. I'm sorry.
Do you want to do? We'll
No,
do your
no,
follow-up
please.
and then we'll go on.
Okay, it's not a follow-up, it's a comment. A lot of organisations are trying to learn from accidents, particularly the airlines and, from my perspective, the oil industry. I used to work for ESSO, and we had British Airways send a man and give us an overview as to how they do it. I'm sure if you asked them nicely, they would. And maybe you could ask ExxonMobil, who live in Leatherhead, whether they could help. Comment. It may be useful, maybe stupid.
Thank you very much. It's a very useful comment. I think there is a the previous Secretary of State was very, very much of the view that all hospital trusts and indeed the whole of the NHS should have a very open and learning culture, and that every incident, accident, issue should be openly talked about, debated and learned from, very much learning from the way that airlines do that. There are other approaches which others may take, but it's certainly something that we're very, I hope that we try to inculcate here a very open culture. James?
There's a very famous risk course that has actually been developed directly from the airline industry experience that lots of hospitals use and we use. And we've also adapted our own local programme, but your point's well made.
I think it's a very good point, just to add that one of the criteria for selecting non-execs is that they have different experiences. So I spent a significant part of my career at BP, so I'm able to bring that. And other colleagues, for instance, from financial services, where when we look at things like whistleblowing, where there's been a lot of external experience, and I find executive colleagues are very keen and open, where perhaps they've only got experience in the NHS. Thank you.
If I can also come in and say thank you. You are pushing on an open door with that kind of attitude. And, you know, it's not just about the crisis management, it's also about improving patient flow. And you might know that one of the well-known examples of this is where the McLaren Formula One team worked with colleagues at Great Ormond Street to improve the handover of critical patient care and that kind of thing. You know, it's something we are so alive to learning about. Thank you.
Thank you.
Yeah, just to return to the finances, at this previous meeting on August 10th with Chris Grayling, there was a commitment made to go back to the Secretary of State with Chris Grayling to see if money could be made available for the reversion to the hospitals rather than having to sell the land. I'm guessing that nothing much has happened because we'll obviously go through the sale of land, but I just wanted to know whether you'd actually managed to get to meet the Secretary of State on this issue.
So Chris Grayling went himself to meet the Chief Executive of NHS Improvement, that's Ian Dalton, twice, and he asked that very specific question, and he was given a very clear answer, which is the control total, so the planned deficit that this trust has been set for the year is not able to be changed, and therefore, as the sale of the land was a part of delivering that control total, if we don't achieve the sale of the land, we will miss the control total, and that will have a big financial consequence to Epsom and St Helier. So that he was told that message quite clearly, and he has discussed the land sale, I'm absolutely sure, with the Secretary of State, who was Jeremy and is now Matt Hancock, and he made it clear to them that he would expect that whoever bought the land would have to have a commitment to social care, which is what he said in the meeting. So I think that is. But you actually should ask Mr. Grayling. But that's my understanding of what he was told and asked.
He went on his own though, without anyone from the board.
Correct. Which was the the decision that the regulator made, that they felt it would be inappropriate to have the trust with Mr. Grayling, but he got access to the Chief Exec of NHS Improvement. That doesn't happen for most MPs, so he's an important man, and he got to meet the boss.
Okay, thanks.
Touching on, because I used to be a counsellor in Epsom, York, my question is, I watched, we know it's care facilities that are needed around here. Have you got any idea of what sort of planning application would go into the Borough Council on whoever buys that land, because that's got an important impact on the sale?
So one of the things that we have been clear about is that Epsom and St Helier is not taking any responsibility for the planning application. So whoever buys the land, that's their risk. It is really very clear that the council has been set a very large target for housing, and there is a need for social care, and there is a need for a whole heap of other things. I think that we made it clear in our prospectus what would be good for the NHS. I think you as the council has made clear what the council needs to see achieved, and I'm pretty confident that the people who buy the land will take account of both those things, because they need to if they're going to make a successful planning application.
All I would say as the Councillor Richard Baker, the Health Liaison Plan Chair, is that we cannot prejudice the planning process, which has to be completely objective.
Yes, of course.
So we can't actually tell the planning committee that we want this, this and this.
Oh, no.
They will look at the application completely independently. Obviously, as a council, we've stated our position very clearly, which is we don't want the land to be sold if possible, but if it is sold, then that should be sold for the purpose of providing a social care facility and or affordable housing for key NHS staff.
Thank you very much, Chair. The accounts, you had two parts that were unqualified. Are they now qualified? The cancer and young people that you're seeing great changes or larger movements, is there any environmental issues that is causing that? And St George's Hospital, there's been reports that I've seen on social media saying they're likely to be flooded with work over the summer or the winter period. Will that impact on St Helier in any great detail?
Okay, I'll answer the last one. Clearly, if St George's is rammed full of people, then ambulances could be diverted to St Helier, and people who self-present could decide to come to St Helier instead of St George's. But by the same token, if St Helier is completely locked up, then people will go to St George's. The capacity that we have in this whole area of southwest London, George's, Croydon, Kingston and St Helier, in terms of emergency care, I'm sure, is going to be very stressed this winter because of the overall demand. I know that London Ambulance are very careful about trying to balance it out. People who self-present obviously will just have to, in a way, they'll tend to go to their nearest place or the place they usually go to. But it is going to be tough, there's no doubt about it. So, and they do obviously have an impact on one another. But it goes beyond southwest London. It'll stretch over from Croydon to Kings, it'll go from St George's further in, and so on. So it's a complicated thing, but yes, they are all essentially interlinked in that sense. Elizabeth, do you want to talk about the accounts?
Yeah. Hello, Morris. The report which I made at the last public meeting talking about the accounts referred to the audit for the year ended the 31st of March. And as I said at the time, we have three parts of our accounts which have to be audited by our external auditors, who are KPMG. The quality account, which is the year-end drawing up whether or not we have achieved all the sorts of things that James was talking about in the interim statement. That was unqualified and will remain unqualified until we get to our year-end, 31st of March 2019. The financial statements, which are what most people think about when they think about the accounts, that was an unqualified audit opinion from KPMG, and obviously we're planning for next year's audit, but we have every expectation of achieving another unqualified audit opinion on that. The qualification related to the value for money audit, which is a rather arcane public sector treasury driven opinion that KPMG had to give on the accounts as at the 31st of March 2018. And so we have now drawn the line under all of that, and rolling forward, we'll have KPMG in to do all of their audit work again, and we will be reporting once again on this in June 2019, which will talk about where we are as at the year that ends next March. We're 8 and a bit months through that now, so obviously a lot of the planning work has continued and is ongoing, and you know, as soon as there's a new set of accounts out, there will be new audit opinions.
Thank you very much.
Thank you very much, Maurice.
And as to your point about environmental factors,
I think you asked 2 questions, didn't you, about whether cancer in children were due to anything environmental. So the seasonal bronchiolitis is a national issue. So every hospital, so I think I mentioned earlier, but when we had a couple of children peaks of arrivals here, I've got a photograph of our whiteboard for every hospital down the M3, from Brighton all the way across to Southampton and Portsmouth. There wasn't a paediatric bed to be had. So the paediatric attendance is very much an issue hitting nationally. For cancer, what's important is not just the rate at which people are referred to us, but actually the rate at which we find there is a positive cancer. So what we're finding is that more and more people are being referred to us, but the rate of found cancers isn't changing substantially. There are small peaks and troughs in that as treatment pathways change. So the difficulty for us as a trust, if I pick on the prostate example, is we have huge variation. We're responsible for the full workup of the patient, but ultimately many of the treatments are given at the Royal Marsden. So at the moment, I'd say it was too early to tell whether there's anything to do with the environment, because at the moment the rate at which we're finding cancers isn't changing substantially. What's changing is the number of patients being sent to us on a cancer pathway. And that might be as much about awareness in GP land or patients asking as it might be about issues to be found. Does that help?
Thank you very much.
Hopefully that's a positive news story, although it causes operational pressures for us in that there's a national drive to encourage earlier referral of potentially suspected cancer. So hopefully we will recognise it at an earlier stage where it is more treatable.
Thank you.
Thank you. Well, thank you everyone for coming, and we'll see you next time. Happy Christmas. And absolutely, Happy Christmas, Happy New Year, and all of that. Great. Good. Thanks for coming.